Welcome to the lecture on aspirin-exacerbated respiratory disease, current management, and future directions. My name is Walid Abuzaid. I'm an associate professor in the Division of Rhinology and Endoscopic Skull-Base Surgery in the Department of Otolaryngology at the University of Washington in Seattle. I have no financial disclosures. We'll begin by defining AERD and discussing its epidemiology, and then I'd like to review the pathophysiology of the disease insofar as we currently understand it. We'll also review the diagnosis of AERD in both medical and surgical management regimens. And finally, we'll end with a discussion of future directions, including new diagnostic and therapeutic modalities on the horizon. Those of us who manage chronic rhinosinusitis currently classify the disease by clinical findings, specifically clinical phenotype as to whether or not the patient has nasal polyps. This, of course, leaves a variety of unclassified subtypes listed here, one of which is AERD. In future, our efforts will move from a phenotype-based system to an endotype-based system, where the subtypes of disease will be classified based on their underlying pathomechanism. That is, the cell type involved or the cytokine expressed. As you all know, AERD, historically called Samter's Triad, consists of hypersensitivity to aspirin or NSAIDs, chronic rhinosinusitis with nasal polyps, and bronchial asthma. The epidemiology of AERD has been quite well defined. We know that AERD affects up to 1% of the general population, and this prevalence is greatly increased among certain groups, specifically asthmatics and asthmatics with nasal polyposis, where up to 40% will have an underlying diagnosis of AERD. Indeed, in a meta-analysis of 27 clinical trials involving adult asthmatics, the prevalence of AERD amongst all comers was 7%. This doubled to 15% if you just looked at the subcohort of severe asthmatics. And in asthmatics with nasal polyposis, 1 in 10 had an underlying diagnosis of AERD. AERD is more frequent in females in an approximate 2-to-1 ratio. They also suffer more severe disease manifestations with faster progression. Typically, there is no significant family history. The age of onset is in the 3rd or 4th decade, though it can occur earlier in females. Diagnosis often occurs 10 years or more after symptom onset, and this can lead to the clinical picture shown here, where you have distortion and splaying of the nasal bone secondary to severe nasal polyp burden. The pathophysiology of AERD is incompletely understood, but we know that arachidonic acid metabolism plays a key role. As you recall, arachidonic acid is metabolized through 2 key enzymes, 5-lipoxygenase, generating the highly pro-inflammatory Cysteinyl-leukotrienes, LTC4, D4, and E4, and cyclooxygenase, generating the prostaglandins. PGE2, one of the prostaglandins generated via cyclooxygenase, acts as an inhibitory brake on 5-lipoxygenase, thereby reducing the level of Cysteinyl-leukotrienes produced. However, PGE2 is functionally coupled to the COX-2 enzyme, and because COX-2 levels are very low in patients with AERD, there is reduced production of PGE2, thereby releasing the brake on 5-lipoxygenase and resulting in increased production of LTC4, D4, and E4. The Cysteinyl-leukotrienes are highly pro-inflammatory and activate downstream mast cells, type 2 innate lymphoid cells, and eosinophils. Furthermore, the Cys-LT1 receptor, which is activated by the Cysteinyl-leukotrienes, is upregulated throughout the airway epithelium in patients with AERD, resulting in the very pronounced bronchoconstriction, mucus hypersecretion, and vascular permeability characteristic of AERD asthma. In a case control study of 137 asthmatics, 64 of whom had AERD, Higashi and his colleagues demonstrated that patients with AERD had the highest levels of urinary LTE4, and that's shown in this figure over here. On the far right, you can see AIA, that's aspirin intolerant asthma. On the far right column, that's the AIA patients who also have nasal polyposis. That's your AERD cohort. And you can see that the mean level of urinary LTE4 is significantly higher than every other category, including higher than that second column, which is those patients with nasal polyposis and chronic rhinosinusitis, but who are aspirin tolerant. The very high levels of urinary LTE4 in the AERD cohort was associated with severe asthma, polyposis, hypereosinophilia, and anosmia. The administration of aspirin, which as you recall, inhibits cyclooxygenase-mediated production of the anti-inflammatory PGE2, drives the levels of urinary LTE4 even higher. Interestingly, sinus surgery decreases urinary LTE4, and this decrease is more pronounced in those patients who have AERD. So again, looking at the right-sided portion of this figure, you can see those patients who are aspirin intolerant, who also have nasal polyposis, that is the AERD cohort, who underwent endoscopic sinus surgery had much higher levels of urinary LTE4 before surgery versus after surgery, and that this effect was more pronounced in that AERD cohort than in the non-AERD CRS with nasal polyposis patients. Patients with AERD also have characteristically high eosinophil levels, not only in their serum but also in polyps, versus those who have CRS with nasal polyposis but no aspirin intolerance. Eosinophils produce a variety of products such as eosinophil cationic protein, IL-4, tumor necrosis factor alpha, and interferon gamma, which further drive the pro-inflammatory cysteinyl-leukotriene synthesis and upregulate its end receptor, Cys-LT1. This is a positive feedback mechanism that further drives the pro-inflammatory cascade. Interestingly, chronic treatment with LT1 receptor antagonists doesn't actually relieve the key symptoms in AERD any more so than it does in non-AERD patients. And furthermore, using drugs to deplete the levels of eosinophils does not produce a clinical benefit in nasal polyposis, whether or not the patient has AERD. This suggests that there might be mechanisms beyond leukotriene mechanism that are likely to be involved in the pathogenesis of AERD. Mast cells are an increasing focus of AERD research. As we discussed previously and as shown in the diagram, you can see the eosinophil over here resulting in overproduction of the cysteinyl-leukotrienes, as well as upregulation of the Cys-LT1 receptor, resulting in a variety of downstream effects. Interestingly, even if you blockade the Cys-LT1 receptor, you still get a reduction in FEV1 on aspirin challenge in AERD patients, suggesting that there's something else at play. And that something else might be mast cells, which may be the linchpin mediating signal transduction from upstream cytokines, such as IL-33, and downstream effectors through PGD2. PGD2, we know, is a prostaglandin which is highly pro-inflammatory. It is a potent bronchoconstrictor, and it recruits a variety of pro-inflammatory cells, including eosinophils, basophils, type 2 innate lymphoid cells, into respiratory tissues. In this way, mast cells may act to abrogate and promote the pro-inflammatory response. There are also other key effector cells that may play a role in the pathogenesis of AERD. The type 2 innate lymphoid cells are activated by the cysteinyl-leukotrienes and tend to localize to the upper airway epithelium in patients with AERD. They produce a variety of interleukins as part of a type 2 inflammatory response, and this is believed to play a part in this feed-forward mechanism whereby the cysteinyl-leukotrienes result in the production of cytokines which activate the type 2 innate lymphoid cells, which then produce further pro-inflammatory cytokines, activating downstream effectors such as the eosinophils and mast cells. Platelet-adherent leukocytes are also increasingly a focus of research. These are markedly increased in AERD versus non-AERD patients and controls. Platelets adhere to cells which express 5-lipoxygenase enzyme, and that includes the neutrophils, the eosinophils, and monocytes, and releases arachidonic acid for enzymatic degradation by the 5-lipoxygenase to synthesize cysteinyl-leukotrienes. So these platelet-adherent leukocytes then augment the production of cysteinyl-leukotrienes and in fact contribute approximately 70% of the body's cysteinyl-leukotriene formation. The urinary LTE4 in AERD correlates directly with platelet-adherent leukocyte level, suggesting that this particular end effector may be something that should be a focus of not only future pathogenesis work, but also as a potential target for future therapies. The diagnosis of AERD, like any other condition, begins with a patient history. The first hint of AERD typically comes from a patient-reported episode of asthma following aspirin or an NSAID exposure. along with a coincident history of chronic rhinosinusitis with nasal polyposis features such as facial pressure, nasal obstruction, nasal drainage, and hyposmia, as well as endoscopic findings of nasal polyposis. It's important after that first report of asthmatic episode with aspirin or NSAID exposure to tease out any subsequent reactions. In patients who have asthma with chronic rhinosinusitis, they have an 80% chance of a positive aspirin challenge. That is an 80% chance of having AERD if they've had a history of a single NSAID reaction. That bumps up to 90% if they've had a history of 2 or more NSAID reactions. Patients with asthma symptoms on aspirin or NSAID exposure, or patients with nasal polyposis and asthma, all require further workup for potential AERD. The typical progression through the symptoms of AERD is as follows. Usually begins with rhinitis, followed by 2 years with manifestation of asthma symptoms. Another 2 years, they begin to manifest aspirin intolerance, and then finally nasal polyposis. So it's important to note that the aspirin intolerance may not be evident early on in the disease course. Diagnostic confirmation of AERD is performed through the aspirin challenge, which is typically administered by our allergy immunology colleagues. This is the gold standard. It can be administered via an oral route, bronchial nasal inhalation, or intravenously. There are a number of contraindications, including a recent myocardial infarction, the use of beta blockers, or uncontrolled asthma. The oral challenge protocol was initially described by the Scripps group in San Diego. This involves holding all antihistamines, as this can potentially block the response and cause a false negative. Patients are pre-dosed with leukotriene modifying drugs, as these tend to abrogate the most severe responses, such as systemic reaction. And they have to have some semblance of asthma control, so an FEV1 greater than 1.5 liters or greater than 60% of predicted, which is checked regularly every hour throughout the protocol. You then observe for reactions after administration of the aspirin, which typically occur within 30 to 120 minutes of administration of a dose. These can be very limited nasal-ocular reactions alone, or the more classic reaction, which is nasal-ocular symptoms as well as a decline in their FEV1. Some patients will manifest only lower respiratory tract symptoms, and even a fewer proportion will have severe symptoms such as a laryngospasm or full-blown systemic reaction requiring the use of epinephrine. The protocol, as shown here, is kind of your standard Scripps protocol, which is a 2-day protocol with a gradual escalation. This is fairly time-consuming. Accelerated protocols have been described, and these take place over a single day and over the course of about 6 hours. You can take a patient from absolutely no desensitization through a full challenge all the way through to a maintenance dose of aspirin. And these are widely used, and their safety has been shown in numerous studies. So this schematic indicates a diagnostic algorithm. In patients who you suspect of AERD, or as they call it in Europe, NERD for NSAID-exacerbated respiratory disease, skin prick testing using aspirin or in vitro tests are not validated, nor are they recommended either in Europe or the United States. As mentioned, an oral bronchial or a nasal challenge with aspirin are validated methods, and a positive challenge consists of the development of upper respiratory symptoms or a decrease in the FEV1 greater than 20%. If you reach the final dose, which is 325 milligrams, and you still see no reaction, then the patient definitively does not have AERD. Timing of the aspirin challenge in the context of endoscopic sinus surgery is of critical importance, and my research group conducted a prospective observational study that involved 28 patients with proven AERD who were challenged before and about a month after endoscopic sinus surgery. Endoscopic sinus surgery actually suppressed the reaction to the aspirin challenge. That is, every patient had a clinical reaction that was diagnostic to aspirin challenge before surgery, but 43% had no detectable reaction after endoscopic sinus surgery. And that cohort that had no reaction typically had lower baseline blood eosinophilia, a lower PGD2 to PGE2 ratio, and lower levels of urinary LTE4. The conclusion here is to establish the AERD diagnosis with an aspirin challenge before you operate in those in whom you have suspected disease, and offer aspirin desensitization and maintenance therapy after surgery in those in whom you've established a diagnosis. The surgical management of AERD has come a long way. As with any patient with CRS in whom you're planning endoscopic sinus surgery, the gold standard is a non-contrast CT scan of the sinuses at a high resolution with 0.625 to 1 millimeter slice thickness, triplanar reformats that allow for intraoperative stereotactic guidance and preoperative review. This quantifies the extent of disease. 94% of patients with AERD will have complete opacification of their sinuses and some degree of mucoperiosteal thickening. And as you can see here, in comparison to the normal triplanar formats in the top row, the AERD patient on the bottom row has complete opacification of their maxillary, ethmoid, sphenoid, and frontal sinuses, which is readily evident on these scans. The goals of surgery are to reduce polyp burden, to reestablish drainage and ventilation of the paranasal sinuses, to allow for postoperative surveillance of the sinonasal cavity in order to detect early polyp recurrence in the clinic environment, and critically to optimize delivery of topical medications into the paranasal sinuses. The failure rates of endoscopic sinus surgery are significantly more common in patients with aspirin-exacerbated respiratory disease. As we know, the effectiveness of topical corticosteroids is entirely dependent upon their distribution into the sinuses. And though standard endoscopic sinus surgery facilitates penetration of these medications into the sinuses, these sinuses can fail through technical shortcomings, be it the mucosal stripping during a frontal sinusotomy, retention of some of the ethmoid partitions, retention of uncinate process. Mucosal remodeling and polyp recurrence can also obstruct a adequately opened sinus. Irreversible ciliary loss and dysfunction can result in mucus stagnation, bacterial superinfection, the formation of biofilms, and further augmentation of the inflammatory response within the sinuses. We do know that more aggressive surgery improves delivery, and we'll touch upon some of that evidence now. So firstly, the extended maxillary antrostomy procedures. You can see in the coronal image here, a standard maxillary antrostomy has already been performed on the left side. The medial maxillary bone highlighted in red there is removed as part of an extended maxillary sinusotomy, or the so-called Mega-Antrostomy, which is demonstrated in the video to the right. Firstly, the middle 1/3 of the inferior turbinate is resected using hand instruments. That exposes the medial maxillary bone, which can then be addressed using either hand instruments as shown here or a diamond drill burr. The important thing is to open that opening all the way down to the level of the nasal floor and to extend it anteriorly as shown here beneath that anterior remnant of the inferior turbinate so as to preserve Hesner's valve. The contents of the maxillary sinus can then be accessed and evacuated as needed. Here there's a bit of a scar band at the natural ostium, which we're addressing to reestablish drainage at the natural ostium, and then finally cauterization of that posterior stump so as to prevent postoperative bleeding. The Mega-Antrostomy is effective in enhancing irrigation and delivery of topical medications through the creation of this gravity-dependent drainage system. In a retrospective review of about 100 patients undergoing maxillary Mega-Antrostomy, about 3/4 reported a significant symptom improvement. If you look at the figure on the right, this is a subcohort of patients from that study who underwent only maxillary Mega-Antrostomy and no other concurrent sinus procedures, thereby isolating the improvement in SNOT-22 to just that brought about by the maxillary Mega-Antrostomy. You can see that over the course of the 4-year follow-up, there was a significant improvement in postoperative SNOT-22 scores in patients undergoing maxillary Mega-Antrostomy relative to their preoperative scores. Then let's move on to talk about extended surgery for the frontal sinus. The standard Draft 2A frontal sinusotomy generates an opening approximately 5 millimeters in size. It's important to note that if the opening is smaller than 5 millimeters, there's an approximate 30% obstruction rate. And the minimum diameter that's adequate for drug distribution into the frontal sinus is 3.6 millimeters. By contrast, the endoscopic modified Lothrop procedure creates a wide open single frontal unit that communicates both frontal sinuses through a common opening. The average intraoperative diameter of a endoscopic modified Lothrop opening or a draft 3 opening is 11 millimeters, and the average postoperative diameter is about 10 millimeters, greatly facilitating drug delivery and reducing the risk of stenosis and obstruction in the postoperative period. The procedure itself starts with removal of the anterior edge of the middle turbinate and performance of a superior septectomy in order to reveal the floor of the frontal sinus, which is then removed using a diamond drill burr. That exposes posteriorly, as shown here, the cribriform, anteriorly the anterior table, and the intersinus septum, which can be drilled down in order to bring the two sides into continuity. Here we're removing some bony ledges and then using a diamond drill burr to further thin the bone of the anterior table in order to increase the antero-posterior diameter of this large horseshoe-shaped opening. You can see adequate access to both sides, deployment of a steroid-eluting stent in order to facilitate adequate healing postoperatively. Generally speaking, endoscopic sinus surgery for AERD is effective, particularly when it makes use of some of these extended approaches, which are particularly useful in the context of revision surgeries. There's a significant improvement in quality of life scores that's sustained for at least 1 year. The degree of improvement is actually quite similar between AERD and non-AERD patients, and this can be sustained for nearly 3 years with concurrent aspirin therapy. There's also a significant improvement in asthma control with better symptom scores, a reduced frequency of attacks in the 12 months after surgery, fewer outpatient, inpatient, and emergency room visits, and a reduced requirement for inhaled and oral steroids. Objectively, there's a significant improvement in both CT and endoscopy scores. AERD patients have an approximate 10-time higher risk of polyp recurrence after endoscopic sinus surgery than those without AERD. And 80% of AERD patients who defer aspirin therapy require revision surgery within 24 months, emphasizing the importance of coupling surgery with postoperative aspirin therapy in order to sustain an adequate response. Our research group also looked at ways in which endoscopic sinus surgery might help to improve aspirin treatment responses in AERD patients. We had 40 AERD patients who were enrolled prospectively before they underwent endoscopic sinus surgery, all of whom underwent an aspirin desensitization. We looked at a variety of asthma-related as well as quality of life outcomes and stratified patients into those who were unable to tolerate aspirin desensitization, the non-responders, and those who were able to tolerate it, the responders. The non-responders were more likely to be of African American ethnicity, and that's a continued focus of investigation, and also had higher baseline levels of 24 of the 40 patients ended up requiring endoscopic sinus surgery, followed by a second aspirin desensitization. It's important to note that of that 24 patients, 15 of these were deemed non-responders. They could not tolerate aspirin desensitization before their surgery. After the surgery, all 24 were able to tolerate aspirin desensitization and treatment. The non-responders saw a significant IgE increase after their preoperative aspirin therapy, but after surgery, there was no such increase in their IgE. And that blunted IgE increase might be why they were able to tolerate aspirin desensitization after surgery. So in conclusion, antecedent endoscopic sinus surgery may enhance aspirin treatment responses in AERD patients and can convert patients who failed aspirin therapy before surgery to a more responsive, tolerant phenotype after surgery. So endoscopic sinus surgery may be particularly beneficial before aspirin therapy in patients who start with a very high IgE and can make those previously intolerant patients now tolerant and able to take aspirin long term. Let's briefly discuss the medical management of AERD. Topical corticosteroid aerosol sprays can improve quality of life scores and endoscopic scores and reduce polyp size and recurrence, but we know from computational fluid dynamic studies that they are poorly delivered to the frontal and sphenoid sinuses. This can be overcome to some degree by using high volume iso or hypertonic saline irrigations, which can improve outcomes. You can optimize drug delivery with the budesonide nasal irrigations, and there's proven evidence that they decrease nasal polyposis and recurrence rate. They don't suppress the adrenal gland, and they can typically be continued as maintenance therapy after endoscopic sinus surgery and concurrently with aspirin therapy. Antimicrobials, there's really no evidence supporting the use of any antibiotic or antifungal delivered topically. There is some utility to the use of oral macrolide antibiotics for greater than or equal to 3 weeks in terms of reduction of polyp burden postoperatively and improvement of quality of life scores. This is both in AERD and non-AERD patients. And that benefit is actually likely mediated by the anti-inflammatory rather than the antibacterial effect of macrolides. Oral corticosteroids are used in a variety of different regimens. This is my typical postoperative course. The likely benefit of the duration is about 2 to 3 months, but you do get significant short-term improvements in endoscopic and radiologic scores and in symptom scores as well. But it's important to evaluate the significant side effect profile. The risks begin to outweigh benefits relative to the risks of surgery if they're used more than once every 2 years. Aspirin desensitization therapy can be highly effective in AERD patients. The goal is to optimize and maintain asthma and chronic rhinosinusitis controls. It's important that they be avoided in pregnant patients, those who have unstable, uncontrolled asthma, and those with ulcers and bleeding disorders. The mechanism of action is actually unknown, but it is known to reduce cysteinyl-leukotrienes levels as well as receptor levels as well throughout the airway epithelium. Aspirin desensitization therapy is similar to the aspirin challenge discussed earlier, the difference being that the dose is escalated to the maximal 325 milligrams, and then the patient is discharged home on a maintenance aspirin therapy dose that they continue indefinitely. Patients are pre-treated as kind of outlined here and typically undergo endoscopic sinus surgery about a month beforehand, which optimizes response as we discussed. The escalation protocol is kind of shown typically here on the right. Most reactions will occur at around 45 to 100 milligrams of aspirin, but it's important to continue escalation until a positive reaction is met, and then this reaction is managed appropriately. After achieving a positive reaction, you repeat the provoking dose. Typically, there isn't another clinical reaction with that second provoking dose. And then the dose is just increased incrementally to 325 milligrams before discharging the patients home after an observation period. We know from a variety of clinical trials on this very busy slide that you do see an improvement in symptom scores, an improvement in olfaction and nasal airflow, as well as a reduction in overall revision endoscopic sinus surgery rates as well. Leukotriene modifying agents such as montelukast, xyluten, zafirlukast also have a role to play. The trial of these LTMDs may be considered in patients with persistent symptoms of AERD. They have a utility as a pre-treatment drug before aspirin desensitization, as I mentioned. There really has been no head-to-head evaluation between agents, nor any trials evaluating the efficacy of combining these different agents that, as shown on the schematic here, work at different points of the arachidonic acid pathway. Immunomodulating biologics have really revolutionized the treatment of AERD, particularly in those patients with recalcitrant disease. Dupilumab is a fully humanized monoclonal antibody that inhibits IL-4 and IL-13 signaling and is approved for use in inadequately controlled chronic rhinosinusitis with nasal polyposis and in patients with uncontrolled severe type 2 asthma, and is therefore approved for patients with AERD. The efficacy and safety of dupilumab was evaluated in patients with severe CRS with nasal polyposis across two large multicenter randomized controlled trials involving adults with bilateral CRS with nasal polyposis that was refractory to medical and surgical therapy. There are two studies, Sinus 24 and Sinus 52. You can see the randomization regimen here. The primary endpoints were the nasal polyp scores and nasal congestion, but they also looked at secondary endpoints, including the CT radiologic scores, the quality of life SNOT-22 scores, olfaction, as well as asthma control measures. It's important to note that nearly a third of the patient population had AERD, and their outcomes were near identical to the patients without AERD. If you drill down into the results as shown in the graphs over here, in the Sinus 24 study, there was an improvement in nasal polyp scores over the 6 months of treatment and then deterioration when the patient came off treatment. Sinus 52 study with a year-long worth of treatment, you can see that the nasal polyp score continues to improve over the course of the year. Similarly, nasal congestion scores in Sinus 24 improved while on treatment with a slow deterioration off treatment, and in Sinus 52 continued to improve over the course of the 52-week treatment protocol versus placebo. The complication rate was significantly lower in the treatment arm, interestingly, versus the placebo arm, and so the dupilumab appears to be safely tolerated. Importantly, interventions were significantly reduced in the dupilumab arm. That is, the use of oral corticosteroids or endoscopic sinus surgery appeared to be delayed in those on dupilumab versus those in the placebo group. What does the future hold for the diagnosis and treatment of AERD? In vitro diagnostic testing is the holy grail and will eventually supersede aspirin challenge. The sulfidoleukotriene release assay measures LTC4 release from peripheral blood leukocytes, and the result is reported as a quantitative number rather than a qualitative yes or no, unfortunately. And it isn't often reproducible and has yet to be validated. Basophils are readily activated in AERD, and measuring this activation has been postulated as a potential diagnostic test. Unfortunately, results thus far have been inconsistent. The 15 heat generation assay is based on the premise that this particular molecule is released more readily from nasal polyps and leukocytes in patients with AERD on aspirin challenge. The sensitivity and specificity is reasonably high in a highly selected population, but the test requires continued refinement since it isn't readily reproducible in a more heterogeneous population. New clinical therapies are also under investigation. Cysteinyl-leukotrienes induce a pro-inflammatory platelet leukocyte aggregate formation, which is modulated through the P2Y12 receptor. Antagonists of the receptor, such as prasugrel, are currently under investigation. Thromboxane receptor antagonists seem to work in murine models, and one particular antagonist is currently in phase 2 testing. The CRTH2 receptor, which is the receptor for PGD2, is currently being investigated as a potential means of blocking a type 2 inflammatory response. And these oral antagonists are also in phase 2 testing. And perhaps a slightly more straightforward approach is dietary modification using either low salicylate diets, which have been evaluated in clinical trials, or low omega-6 fatty acid diets as well. So in summary, AERD diagnosis should be suspected on history and confirmed through aspirin challenge. The optimal treatment involves a close collaboration between allergy immunology specialists as well as otolaryngologists. Gold standard of treatment involves both medical and surgical approaches, and future treatments will directly modulate the involved immune pathways. Here's a list of some references, and thank you for listening.